Good afternoon, ladies and gentlemen. Welcome to the post-lunch session. My name is Sanusha Naidu. I'm with the Institute for Global Dialogue. I know this is a bit of a hard session after lunch, so we'll try and be as informal as we can, and it's going to be really interesting because we're dealing with the health sector and looking at South-South cooperation within the sectorial level of health. So we have a very, very interesting panel with me on the dais who are going to provide some very informative and interesting analysis. I'm going to possibly close the session at 4:45, given that we missed about half an hour. But of course, that all depends how we go in terms of discussion. So before I forget, I want to just also ask people to put their cell phones on silent, just in case we don't want to interrupt the speakers or the discussion. Having said that, let me introduce our first speaker, Dr. Andrea de Mello Souza, who's with the Institute for Political and Economic Research, IPEA in Brasilia, in Brazil. And he's got the floor. I'm going to give the panelists about 15 minutes each, and thereafter we'll open up the panel for discussion. Andrea.
Is my presentation on? Yes. Oh, there you go. Okay. Thank you. Thank you, Chair. Good afternoon to all. So the focus of my presentation will be on Brazilian South-South cooperation in health. I will try to explain what is distinctive about the approach of Brazil towards South-South cooperation in health, rather than speak about any particular project, though I will make reference to several of what I consider the most important projects in that sector. And I start by looking at Brazilian domestic health institutions and policies. And the reason I do that is that arguably, Brazilian South-South cooperation has been historically and traditionally based to a large extent on the successful policies and programs that are implemented domestically. So these programs are replicated in other countries and partner countries, but they have already been tested and they had already succeeded by and large in Brazil itself. And health has also been a distinctive feature of Brazilian governance and democratization. The so-called sanitary movement was a wide-based social movement that promoted the principles of integrality and universality. And by that I mean it defended a view of health that's holistic, that combines both prevention and treatment, and that defends universal and free access to healthcare. And these principles were crucially incorporated in the Constitution in 1988, which created what we call the unified health system. So a particularly important provision of this Constitution in what regards health and these principles of the sanitary movement is the one that provides that healthcare is a right of the citizen and a duty of the state. Now, at the time that the Constitution came out and that the unified health system was created, it was a target of sharp criticism from a lot of foreign specialists and institutions. The World Bank, most notably, wrote that this was not the way to go in what concerns the creation of health systems in the developing world. The bank predicted an explosion of demand for healthcare services, which, if provided free of cost, would eventually become unsustainable. However, we have come a long way since then. It's been 30 years, and surely the unified health system has its problems, but it's still there. And actually, I should also mention, there's no other country of a similar size that provides free and universal access to healthcare as Brazil does. So this system is unique in its scale and in the universality that it offers. One particular area where Brazil has also been highly innovative and groundbreaking has been the treatment of HIV/AIDS. The treatment program in Brazil, following the constitutional provisions and the rights it affords, it offers universal and free access to antiretroviral therapies. Again, this was a program that did exactly the opposite of what the conventional wisdom at the time, and particularly global and national health institutions such as the World Health Organization, the Pan American Health Organization, the Gates Foundation, the World Bank, USAID, and others were telling developing countries they should do. The prescriptions all these organizations offered was focus all your scarce resources on prevention. Never mind treatment. Prevention is a lot more cost effective. And this clearly was the agenda of the North. But Brazil did the exact opposite. It provided treatment, and in the end, this proved to be highly cost effective because the cost of providing drugs is a lot cheaper than the cost of hospitalizations. So these domestic developments in Brazil regarding health also were reflected in the country's foreign policy. Arguably, health, more than any other issue area, has been influenced by Brazil in terms of its global governance institutions. And we have several examples of that. The Global Fund, for instance, was highly influenced by the view of Brazil that treatment should be provided for diseases such as HIV/AIDS, and also that generic drugs should be used for the purposes of providing this treatment. Brazil was a founding member of the fund, as it was of UNITAID, which is another global health agency that provides funding for projects to fight not just HIV/AIDS, but also other diseases, and Brazil was also very influential there. Several of the leaders of UNITAID are Brazilian, including the current one, Celso Amorim, is a former Ministry of Foreign Affairs of Brazil. And the first meeting of UNITAID outside of Geneva was actually held in Brasilia as well, which speaks to the influence the country had there. Brazil has also mobilized regionally to defend its health views, particularly in the ambit of the Union of South American Nations, where it created the South American Health Council, which has formed a sort of a coalition to act in the World Health Organization and in other forums, and also the South American Institute for Health Management, which is headquartered in Rio de Janeiro. And actually, this defense of certain health principles have gone as far as the trade regime, the WTO, particularly with what has to do with TRIPS intellectual property rights. There, Brazil has also defended that patent rights should not prevent countries from defending their own public health systems, and particularly from providing access to essential medicines to all. This debate was also taken by Brazil and other countries such as India to the ambit of the World Health Organization, despite the opposition of the US and other high-income countries that argued that intellectual property rights are not the mandate of the World Health Organization and that the WHO has no competence to deal with issues relating to these rights. Nonetheless, several resolutions were approved in the WHO that ensure the rights of developing countries to defend their public health and to ensure access to medicines in the wake of TRIPS. So this is also obviously reflected in the South-South cooperation in health that Brazil provides, this particular view of health and these particular policies and programs that have been implemented at the domestic realm. So South-South cooperation in health has been a part of what has come to be known in the country as a health diplomacy, and has also constituted arguably a very important foreign policy tool. And the emphasis here in South-South cooperation in health from Brazil has been on the so-called social determinants of health. And once more, this is a very different view from the view of the high-income countries, and particularly the US. These countries focus primarily, when they're concerned about global health, on disease control, right? And solving particular health issues, and not the social determinants of health themselves, as Brazil has. Health has also been innovative as a sector of South-South cooperation in Brazil, because it actually was the area where the term structuring cooperation was coined originally, and later it was also applied to other sectors, but the area where it emerged first was health. This is a concept that was coined by Fiocruz, which is a major lab and research center of the Ministry of Health in Brazil. In 2009, it emerged as a critique of the dominant model of international health cooperation as being too passive in what regards the roles of recipient countries, and as promoting a vertical transfer of know-how, of best practices, and of resources from the north to the south. So this critique in particular looked at how there used to be a lack of involvement, ownership, and influence of recipient countries in the process of international development cooperation in health. And obviously, this cooperation almost always reflected the views, the agendas, and the priorities of donors, such as the one I mentioned before, focusing on prevention rather than treatment, which is clearly a view and an agenda from the north. Many African countries, for instance, at the time had about 1/5 of its population, of its economically active population, infected with HIV/AIDS. And for those countries, saying that they should just focus on prevention and let this huge portion of their population die is obviously highly problematic. But this is just an example. There's several others. According to the critique, too, the traditional model of international cooperation in health tended to neglect the deeper causes of health problems. And to tackle these causes, it would be necessary to look at the social determinants of health, as well as to take a holistic approach towards the shortcomings of national health systems. Eventually, the critique would say, the dominant model would not be sustainable nor transformative, because its effects would only operate during the duration of the project, and typically, once the project was over, the donor would withdraw, and the recipient country would go back to the situation where it was before regarding the particular health problem, or even worse, it could go to a situation that's inferior to the previous one when the projects were actually counterproductive. So, based on this critique, the concept of structuring cooperation is one that defends a more holistic, long-term, and transformative development projects. And these projects should be fundamentally based on the capacitation of partner human resources as well as their institutions. So the focus here is very much on the capacitation and a long-term view. I quote here one of the main individuals that participated in elaborating this new concept and in putting it into practice, Paulo Bus. According to him, structuring cooperation in health is targeted towards full institutional development of partners' health systems based on rights, universality, comprehensiveness, quality, and equity. In order to do so, it seeks to build a capacity and generate local knowledge, as well as promote a dialogue between actors, so as to lead to processes in the health sector and build a policy and technical agenda that is appropriate to sectorial development. Thank you. According to another author, Almeida, there are 5 strategic guidelines for structuring cooperation in health. The priority of horizontal cooperation. So the approach here would be not, as the traditional model had it, to focus on specific diseases or health problems, but rather at the integral development of health systems. Focus on capacitation and building capacities, not just individual, but collective and institutional. Regional coordination of initiatives, as I have also mentioned, the involvement of health ministers as key actors in key structuring institutions, but also a close relationship between the ministries of health and the ministries of foreign affairs in the provision of South-South cooperation. So I give a few examples of structuring projects in Brazilian South-South cooperation in health. Lots of them have to do with the very structure, framework, and governance of the unified health system, because other countries have supposedly a lot to learn from Brazilian experience in that regard. But I have also spoken about HIV/AIDS control and how that was groundbreaking in Brazil. And we have projects there as well, most notably the building of an antiretroviral factory in Maputo, Mozambique. There's also others related to vaccination, family health strategy, which is a system that monitors family in poor communities and ensures that their health is in good shape. People's Pharmacy Program is one that provides affordable medicines, again, to poor populations. And the Human Milk Bank Program, which is one of the most prominent ones, actually was cited this morning, as we'll see. But there are a number of other projects that, while not strictly speaking belonging in the sector of health, also have to do with health and have a significant impact in health, such as Zero Hunger Program, the Bolsa Familia, which is a cash transfer program, and a number of others that have to do with family farming as well. So these are examples of health cooperation practices of Fiocruz, which is arguably the most important institution to provide Brazilian South-South cooperation in health. And we can see that most of the partner countries come from Latin America, but Africa also figures prominently here. And the project that has the most number of partner countries is the Human Milk Banks. If we look here at examples of other Brazilian health cooperation practices, we get a sense of the scope of these practices, right? They go from regulation of private health insurance to mental health issues to bone marrow transplants and the like. There are a number of different agencies of the government that are involved that are shown here in the third column. And this first slide focuses on Latin America, but again, the most number of partner countries are in Latin America. And as the following slide shows, Africa also figures prominently. There's a few projects with Asia and the Pacific that have to do also with health insurance. Let me talk briefly about the challenges of Brazilian structuring cooperation in health. As you know, when we talk about development, there's always a downside involved as well, and we shouldn't neglect that. Now, the first one has to do with the fact that a lot of these policies and institutions that work very well in the health sector in Brazil did so because in this country there was a significant mobilization and organization of civil society to provide political support for these policies and these institutions. Now, it might be very difficult to replicate this elsewhere. For instance, in African countries, when a lot of the affected groups by different health problems such as HIV/AIDS are disenfranchised, and where there is no similar political support from civil society and other groups domestically. A second challenge has to do with the fact that structuring health projects, because of their scope, their ambition, and the fact that they're long-term projects, they require very deep knowledge of the realities of partner countries. And oftentimes, Brazil does not have that knowledge. Particularly when we're speaking about projects that have a lot of partner countries, it is difficult to get an adequate appreciation of the realities of each country involved, and that might be a problem. A third challenge has to do with evaluation concerns. Because they're long-term, structuring projects in health oftentimes do not follow the same time frame as evaluation other projects do, right? And because they also very much focused on capacitation, that also provides more challenges for evaluation. Clearly, capacitation can be evaluated, but I would argue it's not as easy as evaluation in other goals of South-South cooperation. And finally, the sustainability of these projects might also be threatened by lack of resources and changes in the political landscape, both of Brazil and of partner countries. As right now we're in the middle of a very significant economic crisis, obviously resources that are directed towards South-South cooperation go down. And if you're talking about a long-term project that has been set in place a few years ago, then that might be very problematic because it might compromise the very goals of these projects. Let me briefly show you how Brazilian South-South cooperation in health has been channeled through international organizations and multilateral sources. So this is the expenditures with the Pan American Health Organization and the World Health Organization from 2011 to 2013. It has fallen in 2012, as the figure shows. However, for the three-year period, it amounts to about 5 billion reais, which in dollars would be over $1 billion, which is very significant. And if we put that in the context of Brazilian international development cooperation overall, this table shows how it reached a peak in 2010. Over 900 million US dollars was spent that year, and this was largely due to the earthquake in Haiti. Since then, again, because of economic crisis, it has gone down considerably. But it's not very easy to grasp what concerns health in this table, because this table has the total of Brazilian South-South cooperation expenditures, and it also breaks it down by modalities, but none of these modalities refer exclusively to health. Actually, most of the health projects would be in the technical cooperation, but we also have some in humanitarian cooperation and refugees, and obviously also expenditures with international organizations. And here it also should be mentioned that the resources that Brazil gives to support these international organizations goes first to the UN system as a whole, to its secretariat, but next it's the World Health Organization and the Pan American Health Organization. So again, here, when it comes to international organizations, health figures very prominently in Brazilian international cooperation. And I'll stop here because I believe my time's over. Thank you.
Thank you very much, Andrea. That was very informative, and I think you've raised some very important issues in terms of how does the domestic inform the foreign policy, but I think it's also about adapting to your conditions and what works within the local and whether or not you can adapt it to a broader context. But I think the Brazilian health example is instructive, if not informative, about both the opportunities and the challenges with the current political issues that are unfolding there. Our next speaker is Dr. James. He's with the RIS, and I invite him to take the floor and give him 10 to 15 minutes.
Thank you, Chairperson, and my esteemed co-panelists. My focus is healthcare sector cooperation, but I'm looking at the issues in a general way, but based on the Indian experience during the last 5 decades. One fundamental principle is that health is one of the foundational sectors of national development. Whatever happens to the health of the people ultimately affects the productivity of the economy and the national development. So therefore, any program you are addressing into health is to be taken as a program for economic and social development and not merely to be limited to the social development aspect of it. So in fact, we were discussing this thing internationally also in the 2015 India-Africa Summit. If you look into the declaration, there it was very clearly stated that health is critical to the development of human capital, which drives socio-economic growth. This perception is what has shaped the India's policies towards health, both domestically and internationally. Now, when we are thinking of the challenges which health is facing today, the most important thing which all countries are committed is to achieve universal health and well-being at least by the year 2030. And these challenges, they will vary from country to country depending on, because some countries have already achieved many of the targets of maternal mortality rates or child mortality, but there are countries which are lagging behind it too much, I would say. When we are talking about a 70 rate for maternal mortality, and there are countries with 793 as of today. So how to carry all of them, these things. And then there are countries who might have achieved it, but they have the problems of non-communicable diseases, cardiac problems, cancer, then also mental distress and all that. So in a way, if you look at it, every country has got something or the other kind of a challenge in the universal these things. And coming to most of the developing countries, the challenges will be in 4 areas. First is the infrastructure. Many do not have adequate number of hospitals, dispensaries, or even primary health center. And then second, of course, goes with the human resources. Where are the people to man those things? What kind of a quality they have these things? And third one, which normally gets a lot of attention everywhere, both domestically and internationally, is the medicines, availability of access, affordability. This issue is there, and also the quality. And a fourth one, which has not been given so much attention in the past, is the diagnostics. The medical devices, how these things are there. Now, what should South-South and triangular cooperation do to address these issues? I mean, given this last so many decades, there are a lot of experience in partnerships, and many lessons could be drawn from that. I am particularly thinking of India's experience, because India's health partnerships were mostly in African countries. There is this Pan-African e-network that is covering 53 countries of Africa. And here it is a use of technology. Telemedicine is a major component of this program. Provision of services in remote and difficult conditions and tailoring solutions regardless of the remoteness of the place is a major achievement of this project. See, specialists in super specialty hospitals, both in India and Africa, the African super specialty was selected by the African Union, so also all these primary centers were there. They are accessible to consultants, say for consultancies for doctors and patients in remote areas. And that assurance that there is a specialist available at any moment virtually, that's a kind of a great morale booster for the doctors, particularly in the remote areas of this thing. So some of the lessons which one could find from this thing is that, one, the projects should be oriented to the felt needs of the South and their particular country of that things. And they should draw it up. That should be the ownership, should be local ownership. This is one of the cardinal principles which India has been putting into these things. Then one can have innovative approaches to reduce the cost by judicious use of technology. In the morning there was reference to artificial intelligence. This is one such one can very well use it. Never shy away from technology. Well-conceived and properly implemented projects using high technology need not necessarily be costly. In fact, it would be mostly the other way if you take a long-term perspective of this thing. Then a kind of multi-sectoral approach should be used. In this Pan-African e-network, what we did was we clubbed education also with these things. There was a provision for education, there was provision for health, medical education, and also for governance part of it. So combining all these things helped the achievement of the objective of the scheme. Then another thing is how to build the local capacity. I'll mention few examples of that thing in the subsequent these things. Then, of course, Andre mentioned about the issue of intellectual property rights. When we think of particularly access to medicines and other things, this poses major these things. You all know that in the TRIPS agreement, provisions were made, flexibilities are there, enabling developing countries and others to use any of those measures for public health these things. But when such measures are being used, what is happening is a lot of political and economic pressures are being exerted on those countries, maybe because of lobbying by the pharmaceutical firms and other things, and insisting that they stop it on that. Say, for example, the number of users of compulsory licenses you could see. So far, India has used it only once, Thailand once for 3 cases, and Brazil also once. That's all. All this after 1994, the provisions were made. It is 2018, so far we are used. So you know how the lay of the land is there. And then there itself has this thing. India has, in fact, showed this thing, how the patent regime can be oriented towards the need for a developing country by including a provision on Section 3D, which is against evergreening, so that generics could come into the market at the earliest and all those things. Then, of course, one major concern nowadays one finds not only in India but other countries also is that access to the latest technology, particularly in the field of pharmaceuticals. And this sector is now witnessing a major shift from this chemical-based drugs to biological pharmaceuticals. And most of the South lack the technology to develop these products and compete with the developed world. Some do not even have the capacity to absorb the technology. They can only import the products. So what can be done on this thing? There's need to develop this thing about it. And that is where I would say the local production capacity, technology transfer, etc. In fact, I would expect Andre to refer to the Maputo experience, which Brazil did in Mozambique to create a local technology development. We did it, our own, one of the private sector, CIPLA, they started joint ventures in many countries in Africa so that the technology reaches there. It is not a question of export market for this country. Then, of course, one area where normally attention people don't pay much, but we have been paying is traditional medicine. We all talk about the modern medicine, but the traditional systems of medicine like India's Ayurveda or China's system of medicine, these are all well-established systems with their own separate pharmacopoeia and all that, and thousands of years. And the medical education itself is running into many years. It is not that just any hacker comes into and does it. So an appropriately integrated traditional system of medicine with modern healthcare can improve wellness of people and many a time reduce the cost of treatment. See, the main good thing with these systems is they are developed indigenously and they are more suited to the target population, both generally from a physiological angle, and they are also generally free from harmful adverse effects having been proven over centuries of use. Unlike the modern system where, for example, now we are finding the antimicrobial resistance. In fact, the latest target is how to overcome antimicrobial resistance. These are the systems which had been in operation for thousands of years, and this issue comes up in a few decades, antimicrobial resistance. So this is where how these systems can be integrated, what can the South do on these matters, that is something we will have to look into and brigade this thing. Now, coming to the conclusion, let me draw a few general lessons from the past experience and what we can do. One is draw up projects based on the felt needs of the locally felt needs. It's not in a, one size fits all, that will not. This is what the South has always been advocating. One size fits all will not go. Particularly in the WTO negotiations, this was the main call by the South. So here also we'll have to follow that pattern. Then adopt innovative technology enabled multi-sectoral strategies. As I was mentioning about the Pan-African e-network, where we used it to reduce the cost and increase the effectiveness. Artificial intelligence can be very well used, particularly to tackle human resource related issues in many of these things. They can work in areas where humans will find it tough to go and to stay on and all those things. They can be very well used in the diagnostic things, medical device sector and all those. Then we were talking about intellectual property. That is where concerted action on international fora is still required. And also in discussions on access related to biodiversity, traditional knowledge use and all that. That is where the South-South and trilateral cooperation should come to the fore and influence the international policy making and all that. Then of course, the biopharmaceuticals, what we need is, instead of a vertical kind of transfer of technology will not happen, we need to say that horizontal kind of transfer and the cooperation among the equal partners, that is what it should do, and develop local capacity. That's it. Thank you. Thank you.
Thank you very much, Professor James. I think you've really sketched out a very comprehensive and insightful plan of how India deals with its health care cooperation. I particularly enjoyed the Pan-African e-network as an example with Africa as an innovation. And also to say that I think traditional medicine is becoming more and more a choice of alternates in Africa as well. And it bode well in terms of the cross-references with the Brazilian case study. Now let me hand over to Ambassador Balakrishnan, and he has 10 to 15 minutes.
Thank you, Chairman. Thank you all. Let me begin by, since the other panelists have focused largely on the health sector, let me focus a bit on the wider aspects of science and technology cooperation in the South-South context, since we also have to discuss the theoretical perspectives. So what are the areas of importance in science and technology as far as South-South cooperation is concerned? Which areas have good potential? Obviously, science and technology is an area which lies at the bottom of an economy's prosperity, growth, and competitiveness. So countries which move ahead in this field will do better, and those which don't, they will fall behind. Let's look at some of the key sectors where cooperation in the South would have good benefits. First, let's look at biotechnology, which is an emerging field, has been emerging for many years, particularly its applications to health, agriculture, and industry. an effort was made to set up the International Center for Genetic Engineering and Biotechnology. It was a South-directed initiative. The idea was to get the fruits of biotechnology into the southern economies. It has been a partial success over 3 decades now. Its center is located in Delhi and Trieste and now in Cape Town. It could not succeed fully because the major advanced countries in the field of biotechnology, notably the US, did not join it. And in fact, they were not, found it would threaten their private sector. Anyway, the whole project has been a partial success. It has resulted in the spreading of biotechnology knowledge to many of the countries of the South through research fellowships and research projects, including malaria vaccine and so on. One hopes that this project will continue, although it's facing, of course, limitations of funding and financing. So sustainability has been a problem, but the project itself has delivered considerable benefits. Next sector, which is obviously of great importance, is the information and communications technology sector and its applications across the entire economic range of activities, ranging from governance to all kinds of production, in fact, reaching out to the civil society. This sector is extremely important and it can result in a major boost to the economy. So that is an area where the countries of the South should definitely work together, and we have considerable experience in India and many other countries which we can exchange and put into practice the lessons. The third area is energy, particularly renewable energy and climate change. As you are all aware, India has embarked on the International Solar Alliance, which is largely aimed at mobilizing finance and, of course, facilitating technology transfer in this field. So this is a field where, as we move ahead and capacity is increasing, cost of solar cells is dropping drastically, and it's becoming competitive with conventional sources of power. So this is a rich area for cooperation and exchange of experiences in the future. And it also has the benefit of helping to deal with climate change. It also has the benefit that we can provide dispersed power in remote locations, including the islands of the Pacific, without expensive transmission and distribution networks. So this is a great area which has a lot of potential. Then we come to something which is causing a lot of concern across the world, that is digital manufacturing and artificial intelligence. People think that this would result in large-scale disruption and displacement of labor. The full implications of this are still emerging. Many areas of artificial intelligence which we are not very sure how to handle it, including in the military sphere, where there's been discussion about lethally armed weapons, intelligent weapons, and who's responsible for them. Who would be responsible for an AI application which commits fraud? Would it be the application or the person who designed it? All kinds of issues are coming up. I think we in the South need to look at this and work together to have a clear strategy to handle the emerging issues. Another area which is very promising is nanotechnology and new materials. This is an area which is the world of the tiny, the nano world, nanometer scale, which is characterized by very interesting phenomena, and a lot of new materials are coming out. It is a very, very rich field for research. Practically every day new papers are coming out about new types of research. It is not a very capital intensive research. This can be done with relatively little investment. So I think this is a challenge for the scientific community in the South to take up, and it has a lot of potential commercial benefits. Another area is the whole area of marine sciences, where many of the countries of the South have rich, big areas of marine ocean space which come under their jurisdiction. This is being depleted. The marine ecosystem is under threat. In India, we have the large marine ecosystem for the Arabian Sea and the Bay of Bengal, where unlike in some cases like the Gulf of Guinea, there is no international framework to protect the marine environment. So this is at high risk, both these ecosystems. Bay of Bengal, we have an FAO project which is partly doing some work. In the Arabian Sea, we have a vacuum as far as the international cooperation is concerned. Similarly, there are many other areas of the globe. There are about 67 or 68 large marine ecosystems. Many of them come in the countries of the south. People in the coastal areas and depend on these ecosystems for their livelihood. Millions of people depend. So we cannot afford to let them get depleted. Then we come to the issue of environmental protection and monitoring. This is a growing problem, including in my country, in Delhi, in big cities. There is pollution of air, water, soil, and foods. So these have to be dealt with. They have a strong impact on public health, and the situation could get much worse than what it is now unless measures are taken. So here again, we can have a lot of sharing of experience in dealing with these problems, and it would be of direct benefit to our people. Let me come to a thematic issue, and that is science and technology has, especially development-related science and technology applications, can be extremely useful in achieving the sustainable development goals. This has been realized, and there is a technology facilitation mechanism which has been in operation for the past 3 years. The idea is to transmit the experience or science and technology knowledge which is useful for achieving SDGs across the South. We need to do more in this through the TFM, exploit it more and strengthen it and make better use of it. As we in the countries of the South look towards exploiting science and technology, we have to do things to make the science and technology ecosystem robust. In many of the countries of the South, there are deficits in the science and technology ecosystem, which results in science workers or technology workers migrating to other promising environments. So unless we fix our science and technology ecosystem, it will be difficult to retain scientific and technical talent within our countries or even attract them. So there are several areas where we need to work on this. First of all, the universities and research institutions need to be made more research oriented, given more targets in terms of research, improving the educational and higher degrees in science and technology and the research environment. Then we have to deal with the issue of IPRs and commercialization of whatever science and technology knowledge is generated. This includes many things. First of all, of course, a strong IPR system. Patenting within the countries of the South is still well below what it should be. Mechanisms for venture capital and finance, business environment, the markets and civil society. And then we come to the other issue, which is the policy of the government and the regulatory systems which affect the science and technology ecosystem. And lastly, of course, not the least important, but very important, is to leverage the diaspora resources. A lot of the countries of the South have scientific and technical talent which have migrated to the countries of the North. And they work there and they produce a lot of scientific output. India, China, other countries. So this diaspora is a valuable resource in science and technology, and it should be attracted back in some form or the other. And that requires an improvement of the science and technology ecosystem. Now let me come to specifically about the health sector. The health sector is one where science, South-South cooperation has a very rich scope covering the pharma sector, medical devices, the use of ICT in medicine, and healthcare services, both primary and tertiary, medical education and research. So practically every area of healthcare, there is scope for South-South cooperation. At the international level, as far as the South is concerned, South-South cooperation in health was largely discussed in the non-aligned movement. This was a decision taken to coordinate the work of the NAM and the Group of 77, and also raised in the WHO forums. In 1990, Yugoslavia, the chair of the NAM, prepared a detailed paper with a TCDC medium-term plan covering 5 years in the health sector in the WHO. WHO itself has a program called Technical Cooperation Among Countries, which covers both South-South and South-North cooperation. The situation, I can quote a recent review in the Pan-African Medical Journal 2017. I can do no better than to quote the summary. Highlights the immense benefits associated with the use of South-South cooperation for health and provides evidence for increasing use of horizontal development coordination mechanisms to strengthen public health services, delivery and socioeconomic development among African countries. Opportunities for South-South cooperation among African countries include areas of disease prevention and control, production of medical products and essential medicines, harmonization of regulatory processes, and health workforce development, among others. However, pitfalls such as poor coordination, inadequate political commitment, lack of conducive policy environments, language barriers, and inadequate financing opportunities for South-South cooperation initiatives present major dilemmas for the use of these mechanisms. So I think it speaks for itself. The specialists from Africa have well pointed to this. Let me give a few examples of South-South cooperation in the health sector. For example, India and Cuba in the field of biotechnology, a successful joint venture between CIMAB of Cuba and Biocon of India produced monoclonal antibody products for head and neck cancer treatment for use in India as well as global markets. So this was a great success story. CIGB of Cuba transferred technology for producing vaccines to Panacea Biotech India. So there is potential for business-to-business collaboration in the South-South framework. The Cuban medical education system has high capacity. It offers medical education to students from Latin America, Caribbean, African and Asian countries at very low costs, despite the effects of the US economic blockade. ELAM, Escuela Latinoamérica de Medicina, is a dedicated medical university for foreign students. Similarly, other countries, including India, can offer medical education facilities to students from the South. For example, for Malaysia and Iran in India. Cuban healthcare system provides doctors for medical services in other countries such as Haiti, Venezuela, Namibia, South Africa, Central America, etc. Emergency medical services have been provided in the case of the Ebola outbreak, the earthquake in Pakistan, occupied Kashmir, etc. A 2007 study reported that since the early 1960s, 28,400 Cuban health workers have worked in 37 Latin American countries, 31,000 in 33 African countries, and 8,000 in 24 Asian countries. The Cuban primary health system has achieved outstanding results, among the best indicators in the hemisphere. 2016 WHO data indicates an IMR of 2.4, which is better than the US, for example. Despite being a relatively poor country under a US blockade, the system is based on a family doctor as a core, with one doctor for every 150 families across the country, operating out of basic, simple health centers. Cuban experience in fighting dengue and malaria using biological control agents and social mobilization techniques, which is mentioned by my co-panelist from Brazil, could be useful for other countries facing these diseases. Countries such as India and Brazil have been providing lower cost ART drugs for fighting HIV/AIDS. There has been strong pressure from the US pharma industry to stop these efforts, including tightening of the IPEA regime under WTO and elsewhere. Similarly, there exists potential to meet the requirements of essential drugs and pharma products from countries of the South. So I will stop here. There are many more examples to illustrate the rich potential for South-South cooperation in the health sphere and in general in many other areas of science and technology. Thank you.
Thank you very much, Ambassador. I think you've really knitted together the role of science and technology with the healthcare system. Now, I won't waste any more time. To Jessica, you have 10 to 15 minutes.
Good afternoon to everybody. Thank you for the opportunity to talk at this panel. As we know, the Agenda 2030 is a global agreement in order for governments assume the development objectives, but first of all, combat the climate changes. The challenge was the real implementation and how the countries are implementing them. For example, finish the poverty doesn't mean put everyone in assistance or social programs, how is happening at many countries of America. But it was to generate investment and employment. This is the first challenge, understand what the countries with their own ideologies want to do. On the other hand, what I see is the kindly language that the agenda used to define the objectives. And that's okay, but in the ground, the real internal agendas doesn't work like that. For example, the goal of safety food and the promotion of healthy lives in our country means that the international cooperation works on genetically modified foods, or fortified foods, and family planification programs. And well, we can go ahead with the genetically modified foods, even that we really don't be sure in the specific damage to health. But we don't think that the family planification has go the way it goes by contraceptives, mandatory sterilization, and abortion. We know, we are sure that the best way to don't have a lot of children without meddling the family lives is to educate the women to be respected. But here we have two problems to solve. One is the intervention of the family make a rupture in our country, because the children are the most secret treasure for the families. It was the same as the Indian history with the Indira government when her son established harsh sterilization policies, and Indira herself had to approach the people again asking for forgiveness. She had been wrong in giving so much authority to her son. But we have to help some way to all those women that had 7, 8, or 12 children. When you was inside the country and hear the stories of those people, you understand that there is another big problem that we have to solve. We live in a patriarchy, so the discrimination of the woman in the rural areas significate that the man take them like a sexual thing. It's not a decision to have or not have sex, and it means that the woman got pregnant all the possible times. We must promote gender equality, but understanding that women and men have different places in the family institution. That's why we could say, educate one man and you will have a good person, but educate one woman and you will have educate a lot of people. The father gives the children a lot of things that the mother maybe has more difficult to give. For example, security, dignity, and all the things that help a good personality for the children. But women gives the inside training of children, give them love, values, virtues. Many of you are fathers, and you are the ones that take your children and make them fly with your hands and pick up them again, because what you have to show them is that the outside and feel the security coming again to your arms. Women take care of children and show them how to love, how the love works. Both figures obviously are important in the life of each children, Even if there's no father or mother, they need someone who plays that role. At my country, in more and more cases, the companies know that for work we have the same capabilities. Maybe women are a little bit more smart because we could have a lot of things in our brain at the same time. And guys, just you have a straight channel to work. If you have any doubt of that, you may look a video called Man Brain versus Women Brain at YouTube. At my country, this work, when you talk about it, works at the high and middle class. Any people could have employment. There was really few companies that doesn't go with this. Each time, more women will be at the top of management companies. The lower class have few possibilities. There are people that can send all their children to school, and others that can't have money to let them go and prefers them to work. And the boys obviously have the preference in the families. In general terms, the Agenda 2030 of the international cooperation, it's not included in Guatemala development agenda. We haven't changed the multi-annual plans in the public entities to join the consensus of the international organisms. But we are definitely with high pressure from the international and multilateral organisms by financial and technical cooperation. That means that we are technically out, but the financial and technical cooperation push some objectives in a transversal way by the government programs. For example, as I already said, by contraceptives and mandatory sterilization and abortion. The poor woman never knows what was they doing with them. They couldn't know Spanish, so they have a baby or they was pregnant, and the hospitals just call them to have a simple procedures and they sterilize them, or abortion babies. As you see, everything sounds great in the theory, but in the ground we have other reality. Another important element of the implementation that have Guatemala in order to development objectives are the peace agreements. In the last 30 years, Guatemala was subscribed about 10 of these agreements, and of those we advance on the specifically objectives of social development. So we are at the same point than 40 years ago. So the theme is not to subscribe those agreements and then be pressured by the international cooperation, but be a political priority and solving a problem of lack political will to implement them. By first, it's very important to know the way we are in each of the interventions we have to implement, work in basic lines and establish the real time we need and the resources we need to invest for that implementation. This is very important to put in order the international cooperation. By now, Guatemala don't have any agenda that allows to articulate all the requests that are made, and that's why everything came with conditions. Guatemala have an additional challenge, the political conjuncture and the corruption. So there is no any confidence in the public institutions to execute any national or international fund. What we really need is to change the state capabilities to implement any development objectives. So as a country, this is not a problem of investment. It's not a problem of money. It's a problem of government capabilities. confidence and management models. So why I'm here, I'm not a political employee, I'm an entrepreneur that take the same risk than other people at my country. We have to do what the corrupted government can't do by now. We need to change the model since the base with social development projects. We are not non-profit organizations because we have to live with the things that we are doing, but we are changing people quality of life, introducing them into the markets with their own well-done products. We have to do like an ant work, as we say at my country, chopstone, going so far from the city and make changes by our own. If we take each of the points of the agenda 2030, we could find a lot of people doing something with them. In my case, with SSC, the project that I started 4 years ago, we are empowerment women, helping them to do quality products, giving them the administration skills, and we had a program of values for them to take care of their families, improvement in their quality of life, reminding their dignity, so they know that they're not just a sexual thing, and they decide how many children they want to have in consensus, obviously, with their husband. They earn money with their work, so they have a new role in the family. They could decide many things. They already understand that children need to go to school, and we help them, putting them in contact with other projects that bring scholarships to study at high school and the university. I'm helping also with another project called Ecofiltro that brings pure water with filters made by clay and other elements. And it was an invention of one older man from Guatemala, and it receives funding from the US. And also, 2 years ago, I started a different project too, and the objective was to found non-political leaders from all the states of my country, be in touch with them and improve them to do a little bit more with their environment. Maybe having a social development project for them to know how is the cost to develop their villages, and for them to have a good impact helping people. The real meaning of this project is to have everywhere honorable people, thinking that in maybe two years we may be a political group that change our country since the root. Now, it's hard to say, but when people that I know, good people, very good people, try to take a place in the government, or they decide to go, they're working then, they decide to go outside because the things inside was very difficult to be honorable. So, but are so many people that, okay, perfect, I have 2 minutes. There are other people that stay there, and you look that in very little time they be mixed with all those things. Okay, I don't want to give you a bad idea of my country because I really love my country, but this is the truth. And I'm here because I want to change this. And when I say that the international cooperation can't work with our government, I didn't say that the ordinary people don't need help. We need it. And we are the ones that are going to change the situation. And we are the ones that will put all the 2030 agenda in the scenario of our country. And I already finished, thank you. And maybe I have the first question to this panel, because I want to know I want to know how the entrepreneurs be inside this international cooperation, you know. Thank you.
Thank you very much. I think that was a very, very informative experience that you brought to the table for policymakers to think about, and thinkers and research think tanks. So I think we have about 15 minutes for open discussion session. Yeah. So I'm not going to even try to summarize because I failed to capture the salient issues and I don't want to be accused of that. So I'm going to open up the floor. I think we'll take about 3 or 4 questions per round. If you could introduce yourself, and also if you could just keep the questions short and directed to any of the panelists, or if it's an open question or a comment. So the floor is open. I think the panel just did a good job.
I want you to answer my question.
Oh, we have a question here. There's one here. Do you have a roving mic? And there's a second one.
Thank you so much for this opportunity to make a comment. Now, especially your presentation, talking about the health sector and most of the projects that are happening in your country, like in the area of intervention, HIV. Most of the time when we talk about such intervention, we mention Africa. But we don't go to Africa and look at the situation of things. That I sometimes find it not, can I use the word, not acceptable. Because in my country, Nigeria, if we take it, there's a lot of intervention in HIV, preventive, a lot of work done by the NGOs. There's so much going on in Africa. But most of the time when you mention Africa, you, in quote, make it a dark place. No. Africa is not like that. So we need to go on ground. Most of the talking, we should do most of being pragmatic on the field. We should be on the field because this is South-South cooperation. We need results. If we need results, we need to be on the field. We don't need to be assuming. Thank you very much.
Thank you very much.
My question is to Mr. Balakrishnan. How has Cuba achieved such low cost and high excellence medical education? Is there any information on that? And Jessica, I must say, Guatemala is not alone in the problems that you so frankly brought on the table. There are people who impede implementation of many schemes in many countries, including India. So I thought I'll sympathize with you. Thank you.
Thank you. There's one in the back there. Thank you.
Myself, Dr. Malti Goel. I want to ask Dr. Balakrishnan, Mr. Balakrishnan, Ambassador. You talked about so many areas, potential areas, where we can have cooperation. But normally, whenever there is a discussion on cooperation, either we have with the not advanced countries, or there is a hesitation in sharing the information, and there are so many restrictions. So the cooperation does not really materialize when we talk of South-South countries, in some cases, especially for India and neighboring countries. I mean, others I don't say so much.
Thank you very much. I'm going to come back to the panel, and then I'll do a second round if that's okay. So I'm going to start off with Professor James. I think there's a question on Africa.
No, I totally agree with him. In fact, that's why there was no reference to HIV/AIDS and all these things. What I was talking was that we conceived this a Pan-Africa e-network. This was actually conceived long back, 2004, and the person instrumental was Dr. J.P. Abdul Kalam. Then discussions were held with the African Union. This African Union who proposed which hospital should it be and where should all be the primary health centers and all set up. And there it is a question of, it's not disease specific. What we are providing was that cost-effective consultation with the super specialty hospitals, both in Africa and India. And that is a morale booster for people in remote villages who are, particularly the doctors, because they always don't have the latest technology or this stuff. They can always consult these things. But the point which he made, that is the most important. That's what the stress of the whole thing. It has to be locally conceived, locally developed, and local demand-driven, these things. Not something which we sit outside and we say, oh, we have this thing, we will give it to them. That's not. What the local population wants, that should be provided to them if one has the capability. Thank you.
Thank you, Chair. Yeah, I'll also address the question posed by the gentleman from Nigeria. I also completely agree with what you're saying. Actually, one of the points I try to make is that if we're going to be successful in implementing, structuring long-term, highly ambitious health projects in Africa, we need to know Africa better than we do. And, and part of the political discourse in my country is that we're very close to Africa, and we know Africa because of historical ties, the slave trade. Brazil is actually the country that has the largest number of blacks after Nigeria. But this is, the argument only goes so far. I mean, how many centers for African studies do we have in our universities? Not many, and they're not that good. I mean, and the realities of the African countries, despite all the similarities, colonialism, imperialism, and the like, it's still very different from our own. Like I mentioned, the political support that we get from some of our projects at home, there's no counterpart in Africa, and that might be a problem if you want to implement those kinds of projects. So again, I agree. Thanks.
Yeah. Question on Cuba, low-cost medical education. Actually, you can't isolate this from the overall development experience of Cuba. The background to this is that Cuba has a very high literacy rate, almost 100%. School education is completely free. University education is free. So they have a good human resource base, and they have a wide network of hospitals. The government decided to set up medical colleges in fairly large number for a small country of 10 million all across, and they leverage this capacity to train students who have a medical degree. They leverage it into their health diplomacy. They even have people coming from the US, particularly from the underprivileged sections, to study medicine. We had some Indian students from the Northeast who got into Cuban medical system, and it's free. There's no tuition fee. There are 100 Pakistani students coming in after the POK earthquake because they went there and saw that the health system was a total mess. So they offered places for 100 of them. So they came there and studied. So it's an outcome of a certain development process. Can't be isolated from the overall system and the commitment of the country to basic health and education at the highest level. I can give you, for example, Fidel Castro went to the extent of saying that even if there is only one child in an isolated village in the mountains, there should be a school. So that kind of political will and commitment was there in the health and education sector. Plus, it's a relatively small country, and social mobilization under a one-party system is not difficult. You can mobilize people. I'll give you an example of dengue. When they had dengue cases in Havana, the method used was every week spray every building, including embassies, no question of immunity, and put all the school children at work to remove all the foci where water collects, including eggshells, tires. So the school children were put into that. So this kind of social mobilization is, you can't put it in, evaluate it in terms of money. I mean, the cost in terms of money of this project was very low. So not a rich country, but in terms of human effort, it was considerable. About technology controls, in the areas I mentioned in the south, there is nothing much of strategic value. The issue of technology controls comes when there is a strategic dimension to certain technology, which comes in the aerospace and in the nuclear sector. The sectors I've mentioned are sectors where there is you might not see much of strategic dimension. Maybe in nanotechnology, there are very small sensors which can be used for strategic purposes, but apart from that, none of them really. ICT, yes, I agree. But barring that, there is no real reason not to share knowledge among the South. Between the South and the North is a different story. I mean, there the decision to share the knowledge may be influenced not just by strategic reasons, but by commercial interests. So, but by now, countries of the South have a significant capacity in S&T, and I think they're now in a position where they can use it. And if you add the strength of the diaspora, which is in the advanced countries, then you have a fairly formidable critical mass. I just want to comment about what our friend from Nigeria said. I think we have a lot to learn from how Africa faced up the AIDS, HIV epidemic. I was posted in Zambia, and I remember the Zambian health system, public health system, the very severe strain under which they operated at the peak of that time. I would say their medical personnel were nothing short of heroic in the way they did it. And the government mounted an excellent public information campaign about HIV/AIDS to sensitize particularly the youth about the dangers. It was so good in quality that people from many countries came to study that and to learn lessons from that. So I can only say that I wish we had also learned some lessons from that. Thank you.
I'll take another round of questions. There was a hand in the back. Yes,
there. I just wanted to ask or say that when we talk of science and technology, we generally talk of the high-end technologies or newly emerging technologies, which seem all right for the developed countries. But if we look into our own technological development, the historical development, we'll find many, many things that we have already used, but which we have discarded on the way. Simple things are like a solar cooker, for example. It's energy saving, and if the scale is very large, it can actually save substantial amount of energy as well as forests. So similarly, there are various things, say cooling by evaporation rather than air conditioning has many benefits vis-a-vis the air conditioners. Similarly, in Rome, you find very cool water coming from the streams through a series of aqueducts. So, that kind of water engineering, which can put together streams that we already know are there and utilize that. Because normally when we talk of technology, we tend to talk only of high-end technologies, but this kind of knowledge, traditional knowledge or whatever you call it, is also there, is also technological in some sense, and can also be adopted on a large scale. I used a solar cooker for several years, maybe 10, 15 years, but now I cannot find it anywhere in the market. Thank you.
Thank you for that intervention. Are we okay for time, Sasha, or do we have to basically cut off here now? So what I'm going to do is I'm going to give the panelists about a minute or less to just do, if they want any wrap-ups, and then we can close the panel. You want to make any statement? Closing remarks? No? Ambassador?
Yeah, I don't think we distinguish between high and low-end technology. Technology is technology. If it's useful, we should apply it, period.
Thank you. Okay. Professor?
Yeah, the point she made is a very distinct. In fact, this is one of the reasons why we were going on talking about protecting and conserving traditional knowledge and using it. In fact, there is much which people can learn from the traditional knowledge, for particularly in the health sector, innovative this thing, practice and all that. So I agree with your observation. Thank you.
Thank you very much. I want to thank the panelists for their very, very salient issues, and I think with that we can go to tea. Thank you.
Thank you. That was
In the front. No. In the back. Thank you. It was very informative.